using products and accessing information online. And there what we've done is partner with the Arthritis Foundation to create a product with an adapted cap that's really easy for people that experience hand pain and dexterity issues because of arthritis to use. The second example is in the UK, and it's partnering with the Dental Wellness Trust to help children from deprived areas to access dental checkups. And we're doing that through a mobile dental hub that is brought out to them in the community in Tesco supermarket car parks. And then the third one is a long-standing partnership we've been involved in for a long time, partnering with Smile Train to help children affected by cleft lip or palate to access the surgery they need to correct that issue, and also doing work to tackle some of the stigma that exists around that condition that children and their families can experience. And then just moving on to the last barrier of bias and prejudice. Again, this has a really significant negative effect on people's mental and also physical health. And again, some statistics to bring it to life. So 77% of citizens in the US experience some form of discrimination every day, and that can be driven by their race, their age, their weight, or their sex, and it can really affect their health outcomes. Moving to the UK, 42% of black people believe their health is not as protected as white people's. And then going back to the US, black women in the US have a 1 in 4 higher mortality rate from cancer than white women, and yet they only represent 5% of the population involved in clinical trials. And finally, ageism is a problem that kind of pervades everywhere around the world, and it comes at a cost. So this is an example from the US, where ageism is leading to excess health costs of $63 billion a year across 8 different major health conditions. And just an example of what we're doing here, and it's linked again to our respiratory health category, and very topical given we're coming out of the COVID pandemic, where not everyone has the same opportunity to rest and recover and take time off from work when they fall sick, perhaps because they don't have the safety net of paid sick pay from their employer, but also because cultural pressure exists to kind of power through and go to work while sick, which we all know is not a very good idea when we have issues like COVID or flu pandemics around. So what we're doing here is partnering with an NGO partner called the Good Plus Foundation to offer microgrants that helps people who might not otherwise be able to afford a day off to stay home and rest and recover when they fall sick to do so. And then we're also working with influencers and with an Emmy Award-winning poet and activist to help combat that social stigma that means people feel pressured to go to work sick even if they have the possibility not to. So just wanted to say a bit about what we're doing to tackle those 3 barriers around health inclusivity, health literacy, healthcare accessibility, and bias and prejudice, and also introduce a partnership that we are involved in around the Health Inclusivity Index. And I'll hand on now to my colleagues on the panel, Charlotte and Emmy, to talk more about that.
Thank you so much. Thank you. Can you hear me? There we go. Thank you so much, Sarah and Tess. Some key points that we heard that I hope resonated with you if you want to tweet these. We certainly heard a lot about partnerships and making sure that those partnerships are not just one-time things, but they're actually sustained in their efforts for longitudinal work. We also heard a little bit about policy, because we know that we can have interventions, but unless you actually have policy level and systems level intervention, which our speakers will talk about next, there's really a need for that in the sustainability space. And we also heard a little bit about social and environmental barriers. So what we're gonna do now is move that intelligence into some systems level and public health sort of lens, if I will, from understanding what health inclusivity is and how it actually differs from health equity, which is a topic that has come up quite often, and really learning about the nuances from our next 2 speakers. So I'd like to introduce Charlotte Erzbol, who's a founding partner of Hansen and Erzbol Agenda, where she does some strategic consultancy in sustainable transformation. She's also worked as a senior advisor to the UN Global Compact and is on the steering committee of the Economist Impact Health Inclusivity Index that we will hear about in just a few minutes. Emmy Michael is also here with us today, and she's a manager in the Health Policy and Insights team at Economist Impact. She has a special interest in health inequalities and social determinants of health, also something that's been on the top of our conversation at the main stage recently globally. Emmy's also a global health research strategist, and her expertise in global health advisory, program design, and healthcare communications really makes her a woman after my own heart. So we're really excited to hear from them and looking forward to seeing how you're going to distinguish between health inclusivity and health equity.
Good afternoon, everyone. Thank you for the lovely introduction. My name is Emmy Michael, and I have the pleasure of representing the Economist Impact Team, which, with the support from Helium, have developed the Health Inclusivity Index. The Health Inclusivity Index aims to assess the state of health inclusivity in 40 countries. And today we'll be presenting some key findings that are relevant to the pharmaceutical industry and the relevance of pharmacists in driving health inclusivity. We'll run you through a bit of a background on the Health Inclusivity Index, what it is, why it was developed, and some key findings that are really relevant for the topic today. So I'll be back shortly to run you through some of the findings, but I'll hand over to Charlotte, who will briefly introduce the index and the context around it. Over to you, Charlotte.
Thank you so much, Emmy, and thank you for having me here. It's really very exciting for the first time, being able to talk about the Health Inclusivity Index for a slightly larger group. So what we thought we would do was just to dive a little bit into what is health inclusivity. How do we define it? Because in many ways, this is a new way of looking at health and everyday health, and what create barriers for us to be able to achieve it, and what makes us vulnerable and resilient. So first of all, a few introductory remarks about the index. It's the first time that we have really dived into health inclusivity, trying to bring out data in 3 different dimensions to look at countries, what makes them able to drive health inclusivity among their populations, and what are the defining factors for that, both at the policy level, at the systems level, and at the individual level as well. 40 countries are part of the index to begin with, so it's also important, as Emmy is talking about some of the findings, not to jump to the conclusion just because one country is right now the best in the index, it's also the world's best country in terms of achieving health inclusivity. But what we're hoping that this will be able to do is that for countries to use this as a baseline for improving their health inclusivity, and through this collective data gathering, also to embark on a collective learning process to see how we can improve. And I think one of the most important insights for me is that health inclusivity doesn't necessarily always connect with a country's ability to invest in health. It's more a matter of a country's way of valuing health among all of its population. So I think let that stick in your mind. And of course also, we're hoping that this index will really spur action. And also to say that since this is a very new area, obviously there are lots of data that we can't access. So this is also to begin a conversation of what drives health inclusivity and what takes away. So let me just start with a few words of what is health inclusivity. And for us to be able to understand health inclusivity, we also have to understand what excludes people from health. And here it's important to also understand that when we are talking about what makes people vulnerable, for us it's really important to ensure that there is this common understanding that vulnerabilities is not the same as putting labels on people. In many ways, when we put a label on people, a diabetic, a handicapped person, a lonely person, we label them and we treat them differently. And what we often do when we do that is that we take away their empowerment, we disempower them, and we take away their agency. Having worked for many, many years in the field of diabetes, I knew how much that actually matters to people coming to their doctor with a diabetes diagnosis and often being treated as people who really didn't know how to take good care of themselves. And the way that they were treated by the healthcare professionals made them shy away from coming to the doctor or to the healthcare system to seek out health, because they felt it was embarrassing that they couldn't take better care of themselves. And that contributed to put them at a point where their agency and the ability to self-manage was actually taken away from them. So when we look at vulnerability, it's important to understand that in any given period of time during a life course, we can all be vulnerable. It's a complex of different factors and layers that can impact our vulnerability. And we saw that very much during COVID, where people that were already vulnerable in society, take, for example, migrant workers, not being able to perform their jobs, having to go back home, many single mothers who were not able to take time away from their family to get immunization and so on and so forth. Just a funny example that I wanted to share with you was, for example, in the United States, where an attempt was made in order to encourage more people to come and present to get vaccinations. And a reward was given of $100 or something for people to turn up for their vaccinations. And what that did was that for a number of particular single mothers, this freed them up to be able to have their children taken care of while they went to the doctors and get their vaccinations. So something that we might not necessarily think about, but all of these complex factors that we need to understand when we're meeting with them. And of course, this is where the pharmacists are coming in, playing such an important role, because often pharmacists are the front lines, meeting people before they go to, if you want, the formal healthcare system. And where it's important that we meet people where they are and understand their different circumstances and treat them where they are, in respect, not with the labels that we might put on them. And I think that's an exercise for all of us to consider in terms of, understanding people's life situations and helping them where they are. And of course, once we understand many of these different barriers, we can also deal with them in a better way. I was part of developing a major initiative called Cities Changing Diabetes, where we tried to understand what these factors were. And just a few examples of what were some of the major barriers for people to take better care of their own health and driving health agency. So for example, in a sprawling city such as Houston, where people would be commuting often up to 4 hours every day to get to and back to their jobs, they were not on the radar of the public health service organizations in the city. But actually, they were very vulnerable because they had sometimes 2 or 3 meals in their car and leading a very sedentary lifestyle. But no one had them on their radar. The same thing in Copenhagen, where we discovered that one of the biggest barriers for health agency was loneliness among men without a job. And they were invisible because they felt embarrassed about their situation. So the last thing they wanted to do was to go and present with any kind of diagnosis, because that fell down maybe to a 10th priority in their long list of other issues that they were trying to deal with. So this is about the social support and the different systems support and how we embrace and meet people in a daily setting. And just to say that, look at this image up here, like an inverted Maslow's pyramid of needs. When there are enough compounding factors that can bring us down to a point in this vulnerability vortex, we lose capabilities to take good care of our own health and maybe to taking good care of our loved ones' health as well. And that's where we need to be met in a different way than often the healthcare system can do. And also think about the fact that on average, You know, we may present to in a doctor's office or in a healthcare system 8 hours a year. So the remaining 800 and how many hours, we are left on our own. And so how do we ensure that we empower people where they are? So this is what the index is trying to look at, also from a policy perspective, and how we can activate the many different actors in society, in the community, to really drive agency and empowerment. So just a few words, and you probably know these visuals, and in many ways they're horrible because they are in some ways already sort of stigmatizing certain population groups, but they're the best that we have. But it's a little bit about why equity matters, but also why inclusivity matters. So here you see, 3 different sizes of young people trying to watch a baseball game. And if we ensure that everyone have equal access to that game by giving them different opportunities for getting higher up, that's equity. But in many ways, it doesn't necessarily always solve the problem. And if you look at this image, you can say that in reality, there are some people that are simply falling off the radar, as I was saying. They become invisible. We don't see them because they don't come and present. They've given up hope that they are either worth helping or that it really matters when they come and present. So in reality, what we want to do is trying to remove those barriers that are keeping people away from achieving their everyday health. And they are manifold. They can be environmental, they can be systemic, economic, individual, cultural, social, sometimes exacerbated by the labels and the stigma that we put on people and the way that we treat them in everyday life. And so being able to understand what those barriers are also enable us to do something about it. So this is what we're trying to do. So this is the definition that I want to leave you with before I hand over the word back to Emmy. That the way that we in this collaboration that has been helpful in building the index and identifying the indicators for how we define health inclusivity, this is the way we define it. So it's a process of removing the personal, social, cultural, and political barriers that prevent individuals and communities from experiencing good physical and mental health and a life fully realized. So thank you very much, and I would love to give back the words to Emmy to give you a little bit more insights about the actual index. Thank you.
Thank you, Charlotte. Really helpful background on why the Inclusivity Index was created. So today I'll be running you through a bit of an introduction and context on the index, particularly around its methodology and how it was created. And then I'll be going through how pharmacists are represented in the index and what therefore their role in supporting health inclusivity is deemed to be based on our findings. So, as Charlotte went through earlier, the index assesses a country's policies and processes across 3 domains. It aims to assess health inclusivity in 40 countries initially, with the view of expanding over the next few years. So 3 domains. Domain 1, health in society. This domain really looks at the strategies and policies that have been put in place to explore the social and cultural determinants of health. Not only to explore them, but to understand what factors a country is using to address the inequalities that stem from them. Domain 2, inclusive health systems, looks at the structure, the infrastructural system that's in place to ensure a country has adopted universal health coverage, but also how the efforts and mechanisms that are in place to expand access to as many people as possible. And finally, domain 3, people and community empowerment. And this really looks at the individual level, how a country has incorporated efforts to empower individuals and communities to be navigators and agents of their own health. This slide provides an overview of the index framework, so the indicators that have been incorporated into the index to assess health inclusivity. Each of the domains that I went through are weighted equally at 33.3%, and each domain has 3 subdomains, 2 of which, as mentioned earlier, look at policies and processes and strategies that have been put in place to address the various components of health inclusivity. The final domain, the spirit of implementation domain, has a slightly higher weighting in that it only includes 1 indicator, an output indicator, which aims to capture the implementation of those policies and strategies and whether they are actually being adopted and actioned upon. So a bit about our methodology. Phase 1 of the development of the index included a deep learning phase, an in-depth review of the literature around inclusivity to essentially develop an initial index framework. This was then taken in phase 2 to an expert panel who reviewed and provided expert guidance on how to finalize the index framework. In phase 3, we collected data across the 40 countries which were piloted in this initial year of the index to gather all the data required to assess inclusivity. And finally, in phase 4, that data was analyzed, it was rationalized, and it was weighted. Throughout the process, we must also acknowledge the support of the steering committee, of which Charlotte is a member, who provided strategic counsel and guidance throughout the program of the development of the index. So, pharmacists in the index. It has well been established that there are global goals associated with the health workforce. Goal 3C of the Sustainable Development Goals advocates for substantial increase in health financing to support a greater recruitment and development of the health workforce, particularly in developing countries. However, it goes without saying that that can come at a cost, particularly thinking about physicians and nurses, which can be a costly investment. Pharmacists are a central component of both the healthcare system, but also of communities. They play a substantial role in supporting the health and well-being of people at community levels, and therefore should be a focus when thinking about expanding the health workforce. In the Health Inclusivity Index, in Domain 2 precisely, the Inclusive Health Systems domain, we have an indicator that explores the density of pharmacy personnel per 10,000 people in a population. And this is based on an existing data source from the World Health Organization. Looking at that in context of the 40 countries we assessed, Japan tops the list and is in the top position for the density of pharmacy personnel at 18.9 pharmacists per 10,000 people in the population, closely followed by Sweden and Italy. In Japan, approximately 58% of pharmacists work in the community, 19% work in hospitals, and 23% in other settings. And we found that between 2000 and 2019, there was a huge shift and an increase in the density of pharmacists in Japan. And this was largely due to a switch to the Bungyo system, which decentralizes, which separates dispensing from prescribing, and many other countries use this approach, like the UK and others. On the other side of things, in the bottom 10, we had Kenya, Ukraine, Uganda, but we also found that across the index, all the high-income countries were in the top 20 position for pharmaceutical personnel, and all African countries were in the bottom 20. 92% of low and middle-income countries were in the bottom 20, and similarly on the other side, 70% of high and upper middle-income countries scored in the top 20 position. Overall, across the Health Inclusivity Index, there was definitely a differentiation in pharmaceutical personnel between across income levels and geographical regions. From a regional perspective, the Eastern Mediterranean had the highest density of pharmacists, whilst Africa had the lowest density. And similarly, when we look at income, we'd see a positive correlation between a country's income group or GDP per capita and the density of pharmacists that they have. So, pharmacists' role in supporting health inclusivity. The first important point here is that there is definitely a positive correlation between the density of pharmacists and the overall score on inclusivity. There are some exceptions to that trend, like the UAE, Jordan, and India, but overall there is a clear value in investing in health inclusivity, in pharmacy, the density of pharmacists to improve health inclusivity. So what does that mean? As mentioned, the Inclusivity Index explores various dimensions of inclusivity, some of which are outlined here. Pharmacists definitely have a role in providing information for self-care. Definitely based on the science, they have the knowledge and expertise to support individuals to be better advocates of their own health, understand what good health means. Person-centered care. There are set studies and bodies of research that definitely advocate for the value of person-centered care. Pharmacists are uniquely positioned within communities to be able to better understand the needs of their local communities and patients and tailor their service provision to those needs to improve health outcomes overall. And finally, health outreach programs. Again, this is an indicator that is explored in domain 3 of the index. Pharmacists definitely can play a role in understanding patterns of health exclusion. To understand inclusion, as Charlotte mentioned, we do need to explore health exclusion, and that definitely happens at local and community levels. Pharmacists, again in their unique position, have a role in understanding what the patterns of health exclusion are and better tailor programs that seek out exclusionary barriers to support health for the most vulnerable people within populations. We will keep it short in terms of the findings. There is a much bigger body of work which can be explored in a few weeks, but ultimately we would love to hear your feedback. How do you think this resonates? What more can we do to explore the role of pharmacists in health inclusivity? Thank you.
Thank you so much, Charlotte and Emmy, for that. I appreciate the sort of segue into really understanding data behind this. As we heard from the first duo, there's a lot of focus on sustainability, right? So we know that systems level approaches have to be done in order to create this body of work that's going to be sustainable in the long run. I appreciate, as a data geek myself, the idea that we have to add stories to this, right? It's not an abstract thought because it actually impacts people every day. And so I appreciate how you've taken that systems level approach and applied data to actually, I always ask, what stories are these data telling us? What stories can we understand so we can understand the impact? What we know in health inequities is that oftentimes the people who are most impacted by our policies and our decisions and our programming rarely are actually informing that process. And so using people-first language to maintain dignity, using that community-based partnerships model so that we're actually amplifying and not assuming people's needs is going to be really important. And I'd like to pivot a little bit from talking about that sort of infrastructure and the key elements of data and using or amplifying the power and agency of people in communities to look at what's going on the practice side and education. So I'd like to invite for our next part of the program, Emma Paulino, and Dr. Terry Huang. Emma is a boss. That's how I usually introduce her. She is a practicing pharmacist at her own community pharmacy in Portugal. She's also the president of the Portuguese National Association of Pharmacies, ANF, and she has been very active within global work, particularly within FIP, and I really appreciate her lens because Emma is the person we're talking about here as the pharmacist working in the community. And it's really important for us to understand, again, going from that high-level sustainability, looking at those data and how we're partnering with people to then see how it impacts community pharmacists who we are calling on to be the most accessible practitioner, to go out there and do work, balancing their own work responsibilities, busy workflows, and having a lot of time to kind of navigate those waters and understand how they can be effective in that medium. We're also joined by Dr. Terry Huang, who is a professor and chair at the Department of Health Policy and Management at the City University of New York Graduate School of Public Health and Health Policy. He's done a lot of work in research and policy leadership in the area of obesity and chronic disease prevention. And what I like about Dr. Huang's approach is he has a very systems-oriented approach to community health. He's also he founded a new public health entrepreneurship platform called Firefly Innovations. So we welcome his perspective as well, as you will see him on the screen here. And we have been notified that we have over 200 participants here, both live and online, and so we welcome you all to the conversation. Before we take questions from the audience, I'd like to hear a little bit from Emma and Dr. Huang, and Emma and Terry, about how do you translate what we're hearing here to the community practitioner who is called upon to do all these wonderful things, and to the space of education. I know as an educator, I often utilize the health impact assessment tool from the WHO in understanding how our policies are shaping our communities, and I'm very curious to see how we can integrate this as well when we're training the next generation of pharmacists to be more mindful of public health. So Emma, I'm going to get started with you, if you don't mind, just introducing your work and see how you bring this relevance to the everyday community pharmacist.
Well, thank you very much. Hi, everyone, and thank you very much for the kind invitation to participate in this very interesting panel, and thank you very much for your presentations. And I think that I can talk for everyone in this room when saying that we are very happy when someone in a presentation says that the pharmacists matter, and specifically that community pharmacists matter, because, again, we are at the front line of care. But I believe it is important that we consider why pharmacists matter in this respect, and it's about location and competence. And we are talking about location, we are obviously also talking about the context, because we are a healthcare professional that people can access without making a prior appointment. We have large opening hours, and obviously we have all those opportunities. But we only matter when we use that location and context to seize every opportunity, and we only matter when we use our competence to take accountability for patient health outcomes. And I think that this is very important to consider. It's not only about the quantity of pharmacists or if they're nicely and sparsely dispersed by a certain geography. It's also about scope of practice and what we are doing, and if we are assuming that responsibility towards the patient. So I think that when we are considering how pharmacists contribute to inclusivity and equity, we must also consider these more qualitative aspects in some sort, but definitely they are the ones that make the difference. Theodore Roosevelt said, people don't care how much you know until they know how much you care. And I think that it's not only about pharmacists and pharmacy teams being highly competent in terms of training, but it's what we do with those competences and whether we really seize the opportunities throughout the patient health journey to really make an impact, a positive impact on the population. And we've seen during this conference, and I'm sure we will see it in other sessions, a lot of results of those issues. We've seen vaccination, and we know that it increases coverage. We have data for that. We have situations where, for instance, in Portugal, we tested the population, and we were involved in mass testing for COVID, and we performed a study at the National Association of Pharmacies measuring the Gini index for the coefficient for inequality, and we saw a very significant reduction of over 50% in terms of the inequality of access to COVID testing, particularly in people in sparsely populated areas, elderly people, and people with poorer, so with lower income, lower income households. So we know that we are able to provide the impact, but I think that we must do much more in terms of the accountability that I was talking beforehand. And going straight to the point in terms of what you said, in terms of the time that we have to dedicate ourselves to these matters, well, I feel that often we feel threatened by technology and the efficiency in logistics. We feel that sometimes we are going to be replaced either by technology or by the efficient logistic monsters that we have around the world. Well, I think that we can, what we have to consider is the opportunities that technology and the efficiency of logistics brings to us to free our time to really contribute to to impacting on patient outcomes and do what we've just seen described here, which is really what the patient expects from us. So in a previous FIP conference, I mentioned that the $1 million question is not about how can I compete with Amazon or with technology. It's really how can I seize better this opportunity from technology and from efficiency in logistics to really make a bigger impact in patient outcomes and really feel integrated in the healthcare system.
That's it, we're done. No, I'm kidding. That was so inspiring. I really appreciate that lens. Dr. Huang, Terry, do you have any insights into how you see this translate in the world of education and public health?
Yes, thank you so much for having me. So, I agree with all the panelists today. Clearly, pharmacists represent a tremendous clinical and community asset that hasn't been fully utilized to improve community and population well-being. I think COVID has demonstrated to all of us that pharmacists can play a critical role in helping the public health system reach deep into communities, including many communities that are historically underserved, where people have little access to good quality clinical care. I think that we do have a lot of challenges in translating this vision into real life practice, at scale. So first and foremost, pharmacists here in the US and probably in many other places around the world are not always recognized legally as clinical providers. That's something that folks are, really pushing to change, here in the United States. And so there are policy barriers currently that then have implications, for financial incentives, how pharmacists could be reimbursed for various interventions, not only in terms of, medication therapy management, but even moving towards expanded scope in terms of preventive screening, not just for COVID, but also for other social and behavioral risk factors, as well as even participating in multidisciplinary teams in delivering clinical as well as behavioral treatments. We do have limited research demonstrating the potential effectiveness in leveraging pharmacists in such expanded scope of work. It can be very effective and even cost effective, but there just isn't really the incentive in the structure in our current system, to actually scale that. And so these are all like opportunities that exist for pharmacists to play a much larger role in community-oriented primary care, in patient-centered medical homes. These, concepts that have been floating around for some time that we but we need to move beyond these barriers, policy and system barriers, in order to actually implement these actions.
Great, thank you for that. I think that, again, what we're hearing a lot of is there's importance in doing the actual programming work, engaging our partners, engaging our pharmacists, But what we're hearing from everybody really is this opportunity, right? How do we seize that opportunity in a sustainable manner, which we all in this room, doesn't matter your practice setting, doesn't matter whether you are practicing in a community or an educator or whatever, there has to be an innate effort for all of us to push pharmacy forward, to advance the scope of practice, to advocate for these changes, and integrate pharmacists instead of just talking to each other with public health across sectors, so we can actually, what we heard loud and clear, get those data, right? Understand how our impact is being measured so we can use it to further policy advocacy, to further our agenda. I know in the US, I'm a public health pharmacist. I work with the public health ministry, the New York City Health Department. And one of the things we're focused on, for example, with the American Pharmacists Association is to push pharmacists to be providers and recognize so that we can start leveraging how that works in order to advance the scope of practice, find these pharmacists in these maybe lower density populations, because we got national data, but within those countries, a lot of times underserved communities don't have the same density of pharmacies around as other more resourced communities do. So I'm gonna take this back. Within the World Health Organization, I'm actually working with another professor, a colleague of Terry's, on commercial determinants of health, right? These sort of higher level systems sort of level of how some of these things shape our systems in terms of public health. So I heard you talk specifically about Haleon's efforts, particularly in partnerships. Any idea, any kind of thoughts about how that sort of social responsibility comes into play, and how do you find some of the sustainable efforts? So we're gonna learn from these partnerships, but what are some key elements that you've found for sustainability that you've had to challenge in your work? Here, I'll pass this along.
Is that working? Right. So at Haleon, what we're looking to do, as you see from the partnerships that we have with the Economist unit here, that we're looking at this, we certainly can't do any of this alone. You know, we've just heard, haven't we, for the last 30-40 minutes of the value that a multidisciplinary team can bring to any of the challenges that we face. And I think as we bring this index beyond this world today in pharmacy, but into the broader awareness, what we're looking to do is then take particular partnerships around the world and actually then really delve more deeply into what the findings are, creating a multifunctional partnership to ensure that we can take those findings, start to really uncover what some of those deeper rooted, more on the ground barriers might be, such that we can then form those partnerships, develop interventions that we'll then take forward into real practice in some pilot markets. And I think it's really important here to say that we won't always get those things right, that we won't always be able to find the right answer straight away, but I think that combination of the work that we do concurrently with policy change, with the patient groups and the communication that we can offer and the support we can offer there, but importantly with the role of pharmacists, say whether that's in the training, the on-the-ground training, or the change management that will be required for those pharmacists on the ground, I think will be so important. So I think with that, Sarah, I just wanted to hand over if there's anything you wanted to add to that.
Yeah, maybe just one build, and Charlotte talked about it earlier, is the importance of involving people who are vulnerable and who might not be as well included as they might be in really deeply understanding their human experience. What is it that is holding them back from being as included as they might be in everyday health, and how can we overcome those barriers and not jumping to assumptions? So a big component of what we want to do in coupling the data-led approach and the kind of science approach from the index, where we've got realms and realms of data, is also combining that with really deep lived experience research, understanding communities who aren't as included and hearing from them what's their lived experience, what's actually holding them back, and also their own ideas of what might make a difference. Because I think involving those communities that aren't as involved as they might be in understanding what would help them is going to be really important. So I'm looking forward to complementing the data-led understanding we've got from The Economist, but also that deep lived experience insight from real people and understanding from them what's holding them back and what could we do in sharing that more widely with yourselves and with other audiences so that together we can think through what would really make a difference and what might be an efficient way of managing the barriers they experience.
Yeah, if I might just add, there is a huge economic cost that comes with not focusing on health inclusivity. And to your question about sustainability, often, and as Charlotte mentioned, health, the majority of our health is outside of the healthcare system. Only 70%, only 30% is within the formal healthcare system. And so this shift and this idea about moving away from the sciencing, focusing on the people and what individuals can do to drive their own health before it gets too late, before it becomes an issue that needs to be addressed within the healthcare system. There is a role definitely in improving self-care, improving the value of health on an everyday level, and ensuring that health is at the forefront of everyone's decision-making on an everyday basis, and that there is the opportunity for that to be the case.
Yeah, and what I would love to add to that is back to the role of the pharmacists at the community level. I think that, there is a collective knowledge of, what are some of these compounding factors that makes people either vulnerable or resilient. And so how can we tap into that fountain of knowledge and lift it up so that we can actually share it and we can improve our, our approach and our ability to address some of those issues. And also is there a role for the pharmacists being sometimes the front lines of meeting people that present with not just a health problem, but all the different factors that are actually contributing to that. Also to lift that up and engage in the community and the stakeholder environment and be a driver for change and bring other parties closer to some of these issues because you'll be the first to see them and see these patterns that might emerge.
Well, I think building up on what has already been said, and I agree with all that has been said, I think that it is quite important that we move towards a system where we are able to feed this information that we collect at the forefront and into the system database so that we can share that information. And this is something that is still not happening in the vast majority of countries, is that integration of information so that we can collect even the determinants of health that contribute afterwards for the healthcare outcomes. We are very much focused on collecting medication history, diagnosis, and all other kinds of clinical interventions because that's what usually is measured within the system, but this sort of information that can transform then into signals that can highlight that that person in particular is at a higher probability of or higher risk to something, then we can really act on the prevention stage. And instead of waiting for people to need the system and to need healthcare, that we can act proactively and at the beginning of the situation. So I think that, again, we need to work on integrating the information systems and to ensure that the workforce is capable of identifying and recording these determinants of health in a way that we can really signal the person before an event occurs and we can act on the prevention phase instead of just reacting to a certain situation.
What I'm hearing is we need better data and we need all of you to tell stories from those data in order to make this effective. Terry, any thoughts on that as well?
Well, this point is so poignant because I think it was in the New York Times today, there's just a damning article about the broken data system here in the United States in terms of public health surveillance. We frankly don't have a system that works well, that's fully integrated from the local to federal level. And that's talking about very basic, tracking of just COVID events or monkeypox events. So we're not even getting to the social determinants of health in this conversation. We got a lot of work to do, here in the US. So, but I completely agree that obviously greater visibility into not only the clinical determinants, but social and structural determinants in communities will give us a lot of insight in terms of how to organize preventive responses. I would say that, I think another piece that we haven't fully talked about today is training and thinking carefully and strategically about how to manage workflow and the introduction of new technologies into the pharmacy workflow. These are critical aspects that will need to be dealt with if we are to translate the kinds of ideals that we're talking about today into real life practice, at scale. I do think that there are, being the academic that I am, I think that there are opportunities for us to really scale up the research in this area. I think we need to create and tap into practice-based pharmacy networks to really begin to do some serious demonstration, project-like research type initiatives. And, when I actually did a little quick review of the literature in terms of what's out there, before today's session, I was really struck by how little there is. There's some early evidence, shall we say, in the U.S. and in parts of Europe, to show again the effectiveness or cost effectiveness of certain interventions regarding medication therapy management, regarding behavior modification. But by and large, the knowledge base, is really quite limited. So, in support of the policy and systems changes that we're all advocating for here today, I do think that we also need to build more of that research evidence base to show what works. And it's not only like the what, it's also the how, right? The implementation strategies and factors that are going to be critical in different contexts to integrate pharmacists, more fully as a member, a key component of the multidisciplinary provider team. And what does that mean for communities? What does that mean for equity and inclusivity? Can we actually demonstrate, in real metrics, the gains, on those dimensions as a result of getting pharmacists, more involved? So I would just kind of, make it a little extra plea here that we also, think about how to include this research piece into the scope of work as we move forward.
Thank you, and I think that also helps answer a question, Emmy, that you posed about what do we do with this inclusivity index and how do we gain those pieces that might be missing. I want to see if anybody has any questions in our audience. That we do have a couple of folks. Oh, there's a question. They will bring a microphone to you. Thank you.
Hi, my name is Jean-François Desgagnés. I'm a pharmacist, community pharmacist in Quebec. French speaking, so my English is not that good, so I'm sorry. First of all, thank you. So interesting. About the index, for example, in Canada, it's such a big country. Is it possible to have certain data for provinces, for regions, for like indigenous people, communities? Because, in Quebec, we have lots of problems, for health system access for people who are far from centers. I live in a small community 5 hours east of Montreal, so even though where I live, I can assure you that my pharmacy is a big part of the city and the health system. So my question is it possible to have data for smaller things that big Canada? Thank you very much.
Thank you for your question. A really important question. The first thing to say is that the index does really explore data at national level. And I'm sure for some countries, particularly high-income countries, potentially Canada, that data does exist at subnational levels, county, province level, but not included in the Health Inclusivity Index. But you do raise a really important point. And for other countries, lower middle income countries, we did try to explore data at subnational and regional levels. But I think, as a point has been raised quite consistently in this discussion, data is a real challenge, and particularly capturing consistent data across countries, across subnational levels is a real challenge. But something that we hope that can be captured in the future of the index, because as you say, at a national level, that isn't much value, but pharmacists' role does really exist at the community level, and how can we explore that using the data is probably a question for the future.
Well, I was thinking that maybe if we can have the equation for the index, if there is additional data, for instance, in provinces in Canada, that we can then build the index for our province or for our municipality. So I think it would be really interesting to get the equation for the index so that we, again, if we have the data, then we can just fill it in and we can have specific health inclusivity index for that specific region, and we can even compare across regions. That was just a preliminary thought, but I think that would be really interesting.
I'm hearing a collaboration come on.
Yeah, I was just going to say a great question, and one of the reasons we wanted to share the initial results is to get crowdsource ideas for how we deepen the insight from the index for the second year when we run it, because in the initial year we were kind of doing a broad-based cut across 40 countries and the data is at a national level, but indeed what we have in mind for subsequent years is where do we need to deep dive more at a sub-national level amongst specific vulnerable communities. So it's great to have that input. And the other thing I just wanted to say is the index is enlightening both in the data that we've been able to analyze, but also in what it's exposed around the data that isn't available, and showing some things that aren't very well measured yet today. So for example, in one of the barriers that I talked about earlier around bias and prejudice, what we found was that data in that area is very limited, actually. And so I think we've got a real opportunity now to learn from the first data cut we have coming out of the index, both what it shows us from the data we have been able to gather, but also what it reveals in terms of the data that isn't yet available. And we'd love to get your ideas on how we can use different data sources, including bringing in the role of pharmacists to help fill some of those data gaps where there isn't yet consistent data available around the world.
Yeah, thank you for a very interesting session. And look, I suppose I'd just like to point out that issues of health equity and inequity occur, as was referred to by our Canadian colleague, within countries as well as between countries. My name's John Jackson. I'm a research pharmacist in Melbourne, Australia, and I agree with the need for data. I appreciate the integrity of the system that's being developed and the like. But I also actually happen to run a not-for-profit pharmacy in inner Melbourne for disadvantaged communities, for refugees and asylum seekers. And could I ask we don't overlook the knowledge of people who are at the front line here and now, who work in this space every day. If we wait for the data, more people are hurt, more people are harmed, more people die. Let's actually listen to the people who are up the front line. One of the things I'd love to see us do is get the opportunity for social prescribing, because the answers to a lot of these problems is not in supplying medicines, it's addressing the social determinants of health, which we know are outside of the health system generally, so social prescribing, and I think pharmacists could do a wonderful job there. So it's more an observation than a question, but just if we can tap into the experience of the pharmacist front line. Thank you.
John, we appreciate that. I know that there might be some conversations that are going to continue, and please feel free to come up and ask some of those questions that you may have. But one of the things I would just like to wrap up and say is that I heard Emma also talk about accountability. And so I'm going to sort of challenge all of us here, both live and who are viewing, to a couple of things to think about in reflection after this session as you move through this conference. One is, how do we change some of the little things, and this has come up subtly here, is with people-first language, right? That we need to hold the dignity of our communities within this. It's a big area of social determinants of health as well. So instead of saying our, hypertensive patient, it's the person with hypertension. How do we change that so we can start thinking about people when we're talking about this, which then leads us to really take the charge in thinking about pharmacists as community partners, right? We also have stories to tell, and in addition to the quantitative data that we've talked right now about needing for more granularity, more disaggregate data, and we can Google these terms, they're all very important for us to understand and research, but you also have access to qualitative data, to stories, to wonderful lived experiences that you serve every day as pharmacists. So when you leave here, what story are you going to tell? How are you going to leverage your experience in advocating for health inequities, against health inequities, for advocating for health equity, but also for advocating for pharmacists to be more involved in community partnership? One of the things I'd like to challenge all of us is to meet new people here at FIP. If you're sitting next to somebody you don't know, or somebody in front of you or behind you, to think about ways in which you can partner to tackle health inequities, to actually talk about social determinants of health, that we can also help inform some of these collaborations. Because again, oftentimes the people who are impacted by these policies and historically oppressive structural determinants of health are not really there informing some of these solutions. And so we need to be, I think that was pretty loud and clear from everybody here today, that we need to partner with those communities that we serve. And the other thing I will challenge you with is to think about how to get involved in your own jurisdiction with advocating for policy for pharmacists to be able to be effective community partners. So I really want to thank all of our panelists here. I know I gave you a lot of reflection, but we have time in Seville as you sip on any beverage of choice to think about these questions, create new networks and partnerships here at the conference, and take this work and inspiration moving forward, not just leaving it here. So lots to think about. Thank you so kindly for our panelists, a big round of applause, and for all of you to join us. So I think we're going to hang around for a couple of minutes, but please feel free to move about in the space, introduce yourselves to us and to new people, and we look forward to chatting with you. Thank you.